Hello, welcome. My name is Aisha, and I'm going to be doing your Module 3 exam review videos. I'm aiming to get 3 out there. For this first one, we're just going to be going over the big picture. A lot of it is going to be A&P review, but this is the stuff that you absolutely have to understand before you can move on. So, my favorite genre of question to get is, will this be on the test? Yeah, it's all fair game. It can all be on the test. But if you really want some big takeaways, I made this list for you. So how do I open and maintain the airway is going to be pretty much step one for these airway patients, particularly the knocked out ones. More the bigger ones, what is the difference between ventilation and respiration? You need to understand that before you answer the next one. When does a patient need positive pressure ventilations versus supplemental O2 only? At the bottom, a little bit less big, but definitely need to understand what is the difference between internal respiration and external respiration. Gets a little complicated, but you have to know it because the way I put it is it's why we do what we do. And a big one you'll see in red is in what order should I assess and manage airway and breathing problems? It's in red because I have a test taking tip that has to do with this, but I'm not going to tell you right now because I want you to watch the rest of the video. Like I said, mostly airway, anatomy, physiology review. Starting at the top, I'm not going to jump too far into it, but our upper airway, what you really need to know here, what are the structures called? Can you read a scenario-based question where I tell you, hey, something's going on in the oropharynx? Will you be able to identify what that is? Now, throughout this review, when we're talking about the normal processes, I want you to think about what could go wrong. You need to understand what a normal, healthy body does and kind of hypothetically think, I'm getting called to emergencies. Something's going wrong in the body. What could that possibly be? So, with that upper airway, I'm not thinking gas exchange. If I just kind of sip air into my mouth like I'm taking a sip of a drink through a straw, it's not going to constitute breathing. So what do I have the upper airway for? For the most part, it is a passageway. It filters, it warms, it moisturizes. So what could go wrong up here? Really and truly, something could block the airway. This is our door to our lower airways, to our alveoli. We need to make sure that it's open and clear before we do anything else. Something we tend to overlook, at least initially, is the fact that the airway could block the airway. So when we think about airway obstructions, we tend to think like I'm choking on food or something, but more often than not, it's the airway itself. If you look down here, if you're looking at really what the airway is made out of, it's a lot of soft, squishy tissue, and if I'm knocked out, I'm going to lose control of the muscles in my face. It's going to be very prone to just kind of blocking itself, particularly up here, you'll see the tongue. Now, if I'm knocked out, I'm usually laying flat, so that tongue is going to fall into the back of the throat. It's the most common airway obstruction you'll see in the field. If you take a not even a close look, it's a huge muscle. We don't tend to have a lot of room to breathe unless we're breathing through our nose. Now, if that falls back into the back of the throat, that's going to block that most common passageway through the nose. So you'll see, pretty big takeaway, the tongue is going to turn into our biggest airway obstruction. You'll see how that kind of plays into treatment later on. Now, into a little more nitty gritty, we're going to talk about the mechanical movement of really oxygen through the body and the chemical movement. So, this was that question, what is the difference between ventilation and respiration? So, to answer that question, we got to start where oxygen starts, in the air. So, when I have oxygen floating around the air, I need to draw it into my body. I'm thinking about that first mechanical pump up there, the lungs. I'm going to physically move air into the lungs, where they will reach the bottom, the base, the alveoli. So that movement of air from the atmosphere into the lungs is ventilation. When it hits the alveoli, we're going to see an exchange of oxygen from the air into blood. That's an example of respiration. I'll jump into that a little bit more in just a second here, but once that oxygen is in the blood, we hit our second pump, the heart. Blood will return to the heart. You should remember that from A&P. Um, Once it does, we're going to circulate it to the cells of the body. Now, I'll show you why in a little bit, but whenever you think body cells, I really want you thinking brain cells. This will help you out later on in the course when we're thinking about signs and symptoms of various emergencies. Now, we finally made it to the cell. This is where oxygen ends its path. We tend to think of breathing as a cyclical thing, but really, oxygen is just starting one path from the air to the cell. So why do I need to breathe it in at all? What's going on in the cell? I forget why I did this, but in case you forgot, air is in the lungs, blood is in your circulatory system. Hope that helps. But like I said before, the respiration piece, internal and external respiration, it is why we do what we do. Now, what does oxygen do in the body? We remember we have an aerobic metabolism and an anaerobic metabolism, and that aerobic metabolism needs oxygen to create energy. If I put oxygen and glucose into a cell, I'll get ATP, that energy molecule, out the other side. If I have ATP, I can do work, I can think, my heart can beat, I can live, period. Now, we're talking about the respiratory tract, so if you figured we're going to focus on carbon dioxide next, you're totally right. Let's look around the cell for a second. Coming into that cell, I have arterial blood. It's going to be carrying the fuel. It's dropping off the fuel at the cellular level. Oxygen goes in through the cell membrane, glucose goes in, uh, our aerobic metabolism takes place. Now, out the other side, the venous blood has to carry away the waste. Oxygen made its final destination. Now we're starting the path of CO2. I don't know why I think CO2 is just kind of interesting when we talk about respiration. I don't know why, that's just me. So this is our internal respiration. You can remember that as it just doesn't have any access to the external environment. This is going on 100% in the body. Now, like we saw, oxygen finished its path. We're going to start excreting CO2 from the body, starting at that cell where we picked up the exhaust. Those veins are going to bring it back to the heart. And then again, arteries are pushing away from the heart. This is going to be your pulmonary artery, so that that deoxygenated blood can hit the alveoli, drop off that CO2. Now we hit that mechanical movement of air again, ventilation. After I've inhaled and that oxygen has been dropped off, CO2 has been dropped off, the exhale is where I'll see that waste product being excreted back into the air. So let's focus a little bit more on that. When we think about external respiration, it's going to pop up here in a sec, but external respiration, the movement of gases, external, we have access to the external environment, which is kind of a third factor here almost. So when I breathe in, what I'm really focusing on, how I'm getting oxygen into my body, is through this alveolar ventilation, meaning the amount of air that actually reached the alveoli. I'm talking right now, I've got air in my mouth, I've got air in my trachea. That's all dead space. It's not really doing anything. So I'm looking at the air that made it to the alveoli, and what's going to meet that air is blood from the pulmonary artery. This is deoxygenated. We're dropping off those exhaust materials, kind of. So we're dropping off the waste, was the word I was looking for, being carbon dioxide, so we can breathe that out. That is going to exchange into that air. And then we are picking up, again, the fuel that our cells need. We're picking up the oxygen. So this exchanging gases is going to be our external respiration. Again, because I'm ventilating that air into the external environment. If you're kind of sort of following along at this point, it's fine, but you have to have a pretty good understanding of the difference between our mechanical movement in the lungs, ventilation, versus the chemical movement in the alveoli, respiration. Here, I do want to let you know I'm aware of the awkward pauses between the slides. I don't know why, but it won't let me transition smoothly as I'm recording this. Also, I'm aware that sometimes my voice does this thing. Please don't send me those Miley Cyrus memes. If you know, you know. If you don't, let's just move on. So what I've got here, the macroscopic view, meaning what we can see, is going to be ventilation. So I just want to talk about the process of just ventilation a little bit more. So we can see when a patient's doing this, we're looking at chest rise and fall. And our first step of ventilation really is inhaling. So if you just sit at rest, don't breathe at all for a second, and you go to take that breath again, the first thing you're going to do is inhale because that is our active process. You have to activate muscles in order to draw that air in. So as I inhale, as those muscles just do their thing, my chest is going to expand in size, which is going to draw the air in. It's creating that negative pressure, sucks air in like a vacuum. And we'll see this will be really important in trauma. We talk about injuries. That negative pressure not only will draw air in through the mouth, but if I have, say, a hole in my chest, it's going to draw air in through that too. The next step of the process, you're going to relax. Allow the atmospheric pressure around you to squish your chest back to a normal size. And then we'll see that exhale take place. Now, really remember, inhalation, exhalation, it's all a two-step process to take a single breath. Only half of that process should require energy, which remember is made when we breathe oxygen in. Um, I'll give you a little bit more of what I mean when we talk about respiratory distress, but know that only half of this process should be using oxygen, should be using energy. Microscopic is big, I can see it, I can see your chest rise and fall. Then the microscopic piece of the equation is respiration. I can't zoom in on your alveoli and see what's going on, but next stop is going to be assessment, and we have quite a few tools to figure out what could be going on if I have a respiration issue. So that's just kind of visually wrapping up the difference between ventilation and respiration. With all that said, we're going to wrap up anatomy and physiology with covering some differences between adults and children. That's interesting. Faster metabolism is in red. I wonder why that is. But yeah, kids have a faster metabolism than adults. They burn more energy. And because we have that aerobic metabolism, they need to take in more oxygen. So that's why they breathe faster. It's not that they're smaller. You don't need more oxygen. Matter of fact, you would think you would need less oxygen when you're smaller. But they're growing, they're active, they just go through more. So they need to breathe faster. And we need to take that in mind when we ventilate kids, if we need to take over ventilations. Another thing that'll get you here when we're thinking anatomy is the word proportionately. So naturally, a kid's airway is going to be smaller overall than our adult airways. But you'll see on the upper right there, the tongue takes up more space in the pharynx. It's not that it's bigger, it's that it's proportionately bigger to the kid's head. And you'll also see the kid's head is proportionately bigger to their bodies than ours are. The trachea Being narrower, being smaller, softer, and more flexible is going to come into account whenever we ventilate these kids, along with their big old heads. We'll have to make sure that we pat under their shoulders to keep an open airway. It's also more prone to obstruction. And the other thing to note, really note here, that the nose and mouth are smaller and again more easily obstructed. With the cricoid cartilage being less rigid and developed, epiglottis is U-shaped. It's good stuff to know, but not really need to know right now. But first, da diddly da di di da di di da is the test tip that I kind of teased in the beginning. So when you're taking these exams from here on out, you are going to see a lot of scenario-based questions. Basically, you have a patient, you find this, what do you do next? You'll hear this a lot. What is the most correct answer? The most correct answer is whatever you would do first. So, as we're talking about assessment, I want you to consider if I see, say, a scenario based question that says your patient isn't breathing, they have an airway obstruction, what do you do first? Some of the answers might be correct. At some point, I'm going to open that airway. At some point, I am going to breathe for them, but you can only pick one. The most correct answer for those what do you do questions is whatever comes first in the assessment that we are about to go over. And again, that will be true for the rest of class. So as you go through the rest of the class, consider what do my airway and breathing assessments look like? What does my primary assessment look like? So what I mean by the order of assessment, you'll see it listed out in your book, but I want to explain a little more as to why we assess the way that we do. When I mentioned earlier to think about your body cells as the brain is what needs to get perfused. We're really just tracing oxygen from the air to the brain. So starting with the air, the first place that oxygen needs to travel through is the upper airway. We're going to take a look at that first, see if anything's in the way, open it up before we can move on to the next step. As air passes through the upper airway, well, what's causing it to do that? It's being inhaled. So I can inhale if my upper airway is blocked. That's why I'm going to check that airway before I check to see if you are inhaling, exhaling, if you're ventilating adequately. So we'll go a little bit more into it, but when you think inhaling, the air needs to be inhaled, it has to, one, be inhaled in the first place, but two, move at a good rate and a good depth. You couldn't breathe 2 times a minute and call that adequate ventilation, adequate inhalation. Now, as we inhale it, it travels down into those lower airways, and just like with the upper airways, with your mouth, nose, those lower airways, the bronchi, the bronchioles, they can also become obstructed. So, are we moving air adequately? And if we are, is there anything in the way at the bottom? Think about if the upper airway is blocked, I can't move air, period. If the lower airway has some kind of blockage in it, I can probably look like I'm inhaling okay, but still have something at the bottom. And kind of adding on to that, the alveoli themselves can have some obstructions in them. We'll see they can accumulate fluid. So even if the whole track is clear, the alveoli could run into some issues. And what do the alveoli need to meet? Blood. So the meeting of the alveoli to a capillary is necessary for adequate exchange of oxygen into the circulatory system. We'll learn in respiratory emergencies, something like a pulmonary embolism is a respiratory problem, but the problem actually lives in the blood. It's still preventing that transfer of oxygen. So we need that clear upper airway, we need to be adequately moving air, we need a clear lower airway, clear alveoli, and then that alveoli has to adequately meet blood flow. Skipping the heart, we finally make it to the blood. That blood can then travel to the brain and perfuse the brain. So now we know what order we're looking for stuff in. Let's talk about what exactly we're looking for, starting from step one, the airway. Hey, it's me. This is what I look like. I am Aisha. I figured what better way to show you how to assess and awake patients. Now, our unresponsive patients are going to be a little bit more complicated, but one thing you can count on, like I said, is that if you're knocked out, the tongue is going to be in the way. So because we already know that, we're just going to go ahead and fix it. So when I walk up to my unresponsive patient, the first thing I want to know is, are you a medical patient or are you a trauma patient? More often than not, we're looking at medical patients. So to manually open the airway, to get the tongue off the back of the airway, we're going to do that head tilt chin lift. Now with the head tilt chin lift, the entire head, as you can imagine, is moving, but we don't really want to mess with the head in the case of trauma, which is when we'll do our jaw thrust. By moving that mandible forward away from the back of the throat, we can still displace the tongue, but we don't have to move the skull around and risk moving the cervical spine that may be injured in the case of a trauma. Now, like I said, what both of these have in common is that they displace the tongue. This isn't, or these aren't maneuvers to necessarily visualize the airway. This is just a matter of you are knocked out, therefore your tongue is in the way, therefore I'm going to go ahead and move it out of the way. When positioning my patients' airways to make sure that they're open, I have an additional consideration for pediatric patients, and that's going to be padding underneath the shoulders. So I mentioned before that pediatric patients have a proportionately larger head, which means for us that if my patient is lying flat on the ground, that larger head is going to kind of tilt the head downwards. So in order to get that airway in a nice open position, I want to lift the patient's chest by placing something underneath the shoulders, lifting their head up into that nice open position. Now that we've got the tongue out of the way, I don't know what else could be in the airway. Aside from the tongue, you might have a foreign body airway obstruction, which is really anything that isn't supposed to be in your airway, like food or, in the case of kids, toys, stuff like that. So for your foreign body airway obstructions, starting with awake, if your patient's awake and they're telling you with their hands doing the hand thing that they're choking, you're just going to do abdominal thrusts. You know that there is no movement of air, again, because if there was, you would hear stridor, so you're going to go ahead and do those abdominal thrusts. In the case of an infant, though, infants are going to get 5 chest thrusts, flip them over, give them 5 back blows right between the shoulder blades. So that's your pediatric consideration there. Now, in the case of unresponsive patients, as you may have guessed, once again, it's a little more complicated. So I know that in my unresponsive patient, I've already gotten the tongue out of the way. Now I need to look in there. When I look in there, if I can see a foreign body, I'm going to go ahead and just finger sweep it. I'm not going to finger sweep though if I can't see it. My unresponsive patient, I suspect they have choked on something, maybe that's what we were called for. I'm just going to do CPR. Now, I'm going to do CPR whether or not they have a pulse. This is just my algorithm for foreign body airway obstructions. You're going to do CPR as you usually would, 30 to 2. Instead of ventilating, though, you want to look into the airway. So every single time you would usually ventilate, you want to look to see if you can see that blockage again, because it doesn't really make sense to push air into that patient and push that blockage further down. So after you visualize, you just go straight back to the top. Can I see it? If so, finger sweep. If not, keep doing CPR. Now, the other thing that will commonly get in the way of the airway is any kind of fluid. This could be blood, vomit, just something liquid. Now, our kind of universal go-to is going to be suction for that. Just vacuum the fluid out of their mouth. You want to make sure you're not going over 15 seconds. You're not going past the base of the tongue with the suction catheter, all that good stuff. But one thing we don't think about as often is positioning. For instance, if I have a shortness of breath patient, they like to sit upright. That is a way of treating that patient. If I have a patient who is vomiting a lot, they're a medical patient, I can just roll them on their side so that they're not facing the sky and vomiting back into their airway. So suction, yes, absolutely, to get fluid out of the way. But if I anticipate more, go ahead and roll them. Or if I think there's too much in there, or it's super chunky and suction just isn't going to work, roll them over, dump them out like a bucket. So now that we have opened the airway, we've gotten any stuff that was in the airway out of there, we want to ensure we keep the most open airway we possibly can, which is where our airway adjuncts come into play. Now with our nasopharyngeal airways, why do I keep airway, you absolutely should look inside the mouth, that lowest part of the upper airway we can actually visualize, just to see if you can see anything in there. But you are expected to know the airway sounds you might hear. If I walk up to a patient, I can kind of start to tell what's going on if I just hear what their airway sounds like. So with snoring, you can do that right now. You can go by bringing your tongue to the back of your throat, and that's exactly what we're looking at. Again, this is going to be our most common airway obstruction, particularly with our patients who are laying flat, who are knocked out. Um, you can expect to hear that if they do have some kind of spontaneous respiratory drive. With more not the airway itself obstructions, I guess. We have gurgling. So gargling, you can think you gargle mouthwash. That's going to be our fluid that's in the way up there. Now, when you think fluid, there are two big ones you'll run into. You might see blood in the airway in the case of naturally trauma patients, or you might see vomit, or rather hear vomit in either or, trauma or medical. Now with Strider, I think this one's kind of interesting for some reason, but Strider is a high-pitched whistling sound that is caused by a narrowing of the upper airway. So if you think about what you have to do to whistle, I can't whistle, but you have to purse your lips together. If I keep my mouth open and I go, that's not going to create a whistle sound. So what could narrow that upper airway? The first one, which is on the wrong side for some reason, is swelling. Remember, the airway can block the airway, and we're not just talking about the tongue. If I have something like an allergic reaction, anything that can cause inflammation, that can cause the airway to swell up, which can cause that stridor, that high-pitched whistle. The other thing you'll see, a little less common in the case of stridor, is something, a foreign body obstructing the airway partially. So FBAO stands for foreign body airway obstruction. Basically, you're choking on something, but not all the way. Um, We'll get into treatment, like I said, in the next video, but when you're listening to the airway, it'll just give you an idea of what you can expect and how you can start creating that treatment plan in your head. So what I mean by the order of assessment, you'll see it listed out in your book, but I want to explain a little more as to why we assess the way that we do. When I mentioned earlier to think about your body cells as the brain, The brain is what needs to get perfused. We're really just tracing oxygen from the air to the brain. So, starting with the air, the first place that oxygen needs to travel through is the upper airway. We're going to take a look at that first, see if anything's in the way, open it up before we can move on to the next step. As air passes through the upper airway, well, what's causing it to do that? It's being inhaled. So I can inhale if my upper airway is blocked. That's why I'm going to check that airway before I check to see if you are inhaling, exhaling, if you're ventilating adequately. So we'll go a little bit more into it, but when you think inhaling, the air needs to be inhaled, it has to, one, be inhaled in the first place, but two, move at a good rate and a good depth. You couldn't breathe 2 times a minute and call that adequate ventilation, adequate inhalation. Now, as we inhale it, it travels down into those lower airways, and just like with the upper airways, with your mouth, nose, those lower airways, the bronchi, the bronchioles, they can also become obstructed. So, are we moving air adequately? And if we are, is there anything in the way at the bottom? Think about if the upper airway is blocked, I can't move air, period. If the lower airway has some kind of blockage in it, I can probably look like I'm inhaling okay, but still have something at the bottom. And kind of adding on to that, the alveoli themselves can have some obstructions in them. We'll see they can accumulate fluid. So even if the whole tract is clear, the alveoli could run into some issues. And what do the alveoli need to meet? Blood. So the meeting of the alveoli to a capillary is necessary for adequate exchange of oxygen into the circulatory system. We'll learn in respiratory emergencies, something like a pulmonary embolism is a respiratory problem, but the problem actually lives in the blood. It's still preventing that transfer of oxygen. So we need that clear upper airway. We need to be adequately moving air. We need a clear lower airway, clear alveoli, and then that alveoli has to adequately meet blood flow. Skipping the heart, we finally make it to the blood. That blood can then travel to the brain and perfuse the brain. Unfortunately, I have hit my 30 minutes, so this is the end of part 1. I must leave you be. But fret not, there is going to be another video, so I will see you there.